Good morning, everyone. And welcome. And I'm not sure how many of you have had the wonderful experience of catching up with people face to face of late, but how fabulous is it just to chat and check in? And there are some people in this room I haven't physically seen for well over, I'm going to say, a year or 18 months. I may have seen you online, but it is lovely just to see you. And I forgot how much I might have missed that along the way, because I am Leanne Durrington and the CEO of WAFA, but I'm also quite introverted, and I know most of you wouldn't think that to be so, but I love working at home and I love MS Teams, but I have really enjoyed catching up with people face to face. So thank you all for coming along today, and what a wonderful group we have here. So better look at my notes and see what I'm meant to do. Firstly, I was reminded the last physical one of these Better Health Together forums was in 2019. I just thought I'd say that. So we've all aged in place a baby bit because of what was 2020. So this is the fourth of those events, but there's just been a little bit of a dry time between the last one and this one. So today is opportune, as you might imagine, because there was a Commonwealth budget a few days ago, which has kept some of us a bit intrigued and busy trying to read between the lines. But we're going to today try to share with you what it is we understand and know, and in particular have asked Swerissen to help with that. Now, you've probably all found the toilets and the coffee, oh well, there is coffee over there, but you've all found the toilets further down the hall, and what would that be, to the right. And of course, indeed, if there is an emergency, we all just go straight out that front door. Can I welcome, there's a number of the WAFA board here today, which is wonderful. We hadn't seen a lot of them either in the last year. So I'm just going to ask you to wave if you can, because some people may or may not know you. So Stephen Ragg is a director on the WAFA board. And his day job is a pharmacist, I just thought I'd say that, so good to know. Rod Astbury, many of you will know Rod. Mental health networks, I won't go on. Damien Zilm, rural GP. Well, not really, he does things in the city as well, but a GP. I think that's it, isn't it? And we've got apologies from Rhonda Marriott, who's having a road trip around the northern parts of Australia, and Tony Ahern and Richard Chung. But it'd be great for you to catch up and say hello to the directors. We've also got quite a good turnout here of WAFA staff, and that might be nice for some of you to catch up with some of the team. So Mark Cocaine, some of you will have met Mark, but some of you may not in the last 18 months. Giles Nunes, Danny Rock, Chris Kane, and then all of the rest of the wonderful staff who make this event happen. I understand you're all aware that this event is also being filmed, so, you know, put on your camera face if you like, but that's for people who couldn't make it here today, so it is being filmed. May I also just take a moment to recognise and acknowledge the Australia's First Peoples and recognise the land that we're meeting on here today and pay our respects to the Noongar Nation, of which many of you would be working on the lands of the Noongar Nation, and pay our respects to elders past, present and emerging. And apologies from Rhonda, who would have liked to have done that acknowledgement much better than I would have done herself. Now, I'm going to just take 5 minutes because, you know, it's hard to believe we're actually running on time, even though there might have been a delay with the speakers and you all had to mingle a bit longer than we had planned, but we're actually running on time, and I've been asked to just do a bit of an update on the life of PHNs in Australia, notwithstanding WAFA, because of course you can imagine, like all organisations that you also work in or relate to, You know, the world has changed a little bit with coronavirus, and that's kept us pretty busy over the last 12 months in terms of our role with that, but that is a national function. All PHNs have been involved. Notwithstanding, a number of the PHNs were also heavily involved in fires, floods and cyclones. So we've had a year where there was a collision of a whole range of disasters that have required good work to go on around recovery and support of communities. And I have to say, even when we had the fires here up in the hills and we were also dealing with COVID, it was very challenging, not necessarily as much for us, but definitely for general practices on the ground and service providers and so forth. So I think everyone should feel pretty good about the contribution they've made to the community over these last 12 or 18 months. Just in terms of PHNs, you know, we turned 6 in July, and I know I'd heard that Street Doctor turns 20 at the end of this year, so I just thought I'd say that because that is a fantastic thing that Street Doctor's turning 20, but we're turning 6. Hasn't that gone in a heartbeat? And of course, you know, we also are maturing and trying to make sure that we're very clear about what we do, how we do it, and where we do it. And PHNs can be seen as a bit of a, well, they do this and they do that. Well, in fact, it's actually pretty precise what we're meant to be doing, says I. We work nationally as a cooperative, and people may not be aware of that, but we have a range of strategies that sit across Australia that are really important in terms of strengthening primary care. And while primary health networks are specifically focused on regional commissioning and regional solutions to healthcare challenges, we also have a range of systemic functions that sit across Australia. And, you know, for example, with COVID, there was a role that was managed nationally around engaging general practice and then assisting with the distribution of things. You know, I won't go on. But there are also practice improvements, whether it's in mental health or indeed in chronic diseases. So we see ourselves as both national but also having a regional commissioning role. For us in WA though, being, you know, a little bit bigger than some other locations, we also take out that regional focus as being somewhat unique as well. So while we have pretty much, you know, a mandate that sits around us, Mark and I are in Northern this week listening to the local committee and the collaborative and what they're doing in mental health, which is about addressing better pathways of care, better joining up of services in the wheat belt for people. And it was very impressive, the work that was underway around how collaboratively across the system they were doing that work. And that is the work that really excites us, is that sort of stuff, because no one else is going to do it, says I. And it doesn't mean there's not goodwill, but unless you bring the parties together and you have a shared vision and a shared purpose about improving access and improving support, then, you know, best will in the world, you can't do it on your own. And so that was quite impressive, and it reinforces that for us. We have a regional footprint as well as the metro footprint, yet we also try to do certain things statewide. I don't want to make it too hard, it is a Friday morning, but you can get this drift that we move between quite high level but also very regional. Ultimately, the work that was demonstrated in Northern the other day is what we think is critically important about joining up care around general practice. And if people don't have a general practice access, how do we improve that pathway as well? But conversely, how do we get general practice to reach into some of these communities better? So anyway, it was impressive is all I'm going to say. So any of you who come from that part of the world, you've got to be very pleased with the work that's going on there. And to have WACS at the table along with the providers and local government, a bit tricky in the wheat belt because there's 43 of them, but, you know, you really start to see the community-based strengthening of the systems of care. So, oh, by the way, we're moving. I just thought I'd say all of you who love waving at us when you go up Great Eastern will be no longer, because we're moving to Subiaco. I just thought I'd let you know that. And what's that a response to? That's a response to us changing our operating model of a hybrid work mix. So people will spend time together in offices, but they will also work from home and indeed other places. We have really managed this notion of how do we support people well to work in their home office but yet be part of a team, and how do teams come together. So the Subiaco footprint gives us much more flexibility to do that really well, to have the collaborative spaces, and apart from that they can go and meet and have coffee down the street if they want, or catch the train to work. So September-ish I think is the date, and we are really trying to move to that hybrid way of working to have much more flexibility. Many of you would have discovered this in your own environments. A lot of people have enjoyed not having to travel, not having to, whip out of the office to get home to pick somebody up. So we're trying to get that work-life balance and have a hybrid way of doing that works for people. So, we're doing it. We're not on the back page of the Australian yet where all of that hybrid stuff gets showcased, but we are actually progressing this. And we know it's a little bit of an experiment, but we also learnt through COVID it's not one thing or another. There's this point in the middle that gives the balance to not only people having a work-life balance, but how we undertake our work. We'll still have our 7 regional offices. We're not changing any of that, but we will see our footprint from Rivervale change quite dramatically at Subiaco. So anyway, that'll be good news. We'll tell you more about that, but all very exciting for us to be able to create a workspace that works for our staff and our stakeholders. And Subiaco, like all other places, is a little bit interesting, so it'll be a great move for us. Now, I think I'm going to introduce Hal, and some of you will have been to a Better Health Together forum where Hal did present on integrated care. And for those of you who were present, we've taken forward what came out of that workshop and have in our plan going forward some integrated care hubs, as we're calling them, notwithstanding there's work going on integrated care, as I described in Northam. But there are some locations where we think we need to be far more hands-on about how we develop up integrated care. And there will be communities where there may not be the assets in those communities that are in others. So how do we strengthen them? We'll need to ensure that we have the right clinical base, but conversely, all those other assets that sit around a thriving community. So we do thank Hal for his contribution, which would have been in 2019, I think, on that topic. So Hal, I think you can see on the screen, and Hal brings just a wealth of experience to primary care, but not only primary care, health more generally, and of course a regional focus in that as well, and has a fabulous career where you can see how all of that experience, both in academia, in the public sector, Grattan Institute and so forth, all collides to provide a great analysis of where are we going. And the budget, which, to me, had a whole lot of stuff in it, which all sounded great, but how do you make sense of that? And what does it mean for primary health care as we go forward? And what is that agenda that is emerging from that budget? And my sense is, there's a lot of water under the bridge to go, particularly for the states and the jurisdictions, but similarly for PHNs. So Hal's going to, and welcome Hal, thank you very much for giving up your time. Hal couldn't come to WA because when he went home he was going to have to isolate, and we didn't want him to have that experience. So even though the introverts in us, probably can thrive, but you can only do so much of it. And so Hal wasn't able to come physically, but is with us here virtually today. So welcome, Hal. And what we're going to do is do a short overview, and then Chris is going to do a sort of a Q&A with Hal, but we also will take questions from the floor via Slido. So as long as Hal can hear us okay, we might hand over to Hal. Welcome, Hal.
Let me firstly say I'm very sorry that I wasn't able to make it across in person, and it's nice to see you all on the screen. Unfortunately, as you know, the Victorian government is conservative about COVID, and you were all orange up until yesterday, so that meant that I had to quarantine if I came to WA. So unfortunately, I couldn't make that happen. So thanks for bearing with us on this technology. Let me begin by also acknowledging the elders past, present and emerging of the traditional owners on the land on which I'm speaking, which is the Dja Wurrung country in Victoria, in Daylesford. And I am very pleased today to be able to do an overview of the budget, and then Chris and I think we'll have a chat about what some of the implications are. So let me begin by saying that the health budget in Australia is around about a $200 billion a year spend. So the overall amount of money that's spent in health is around $200 billion. And that now is around 10% of GDP. So it's a very significant part of the economy, and it's a very significant part of the Commonwealth budget. The Commonwealth spends around $100 billion a year on health at the moment. About a third of that is spent on primary care, so roughly $65 billion a year, and about $80 billion is spent on hospital. And the other thing that I'll talk a little bit about in the next 10 minutes is the spend on aged care, which is around $20 billion, and the spend on mental health is around $11 billion. That's total spend. This year, the way the budget works, the Commonwealth budget works, is that it's the numbers that you're seeing in the paper are basically numbers which are over what's called the forward estimates. And the forward estimates are actually, normally they're a 3-year period, but this year the Commonwealth's done a bit of a sleight of hand and made it a 4-year period. So the numbers look a little larger than they otherwise would, because they're numbers over a 4-year period rather than over a 1-year period. So the growth over the 4-year period, over the forward estimates, is $5 billion over 3 years, just to make life really complicated. And that means that it's a relatively modest growth overall. On $100 billion, that's about a 5% increase over 3 years. Now, the main areas of growth, as you've all seen in the papers and in the media, have been on the area of aged care, which is a $17.7 billion increase over 4 years. And mental health is a $2.3 billion increase over 4 years. And then there are a range of smaller spends in primary care, and I'll just overview them in a minute. There are also a significant range of COVID measures which have been extended for another year, and there's been a significant extension of funding for the NDIS over the period of the forward estimates. They're the highlights. If I go to aged care with a $17.7 billion increase in spending is a major reform, and it has a significant set of implications for primary care. Much more emphasis on home and community care. There'll be 80,000 new home and community care packages. There'll be a significant reform in the residential care sector with an increased requirement to deliver services. There's a requirement now to deliver 200 minutes a day of service to people in residential care. There's significant increase in spending for quality by increasing the training of staff and increasing the staffing requirements for residential care. In terms of some of the other issues, there's a significant expansion in support for people who are accessing aged care by introducing what are called care navigators, and also an increase in the localisation of aged care, so that there'll be much more, there'll be people at regional level, including the regionalisation of the governance arrangements for aged care, so that the staff in the Department of Health, Commonwealth Department of Health, will now be located more in local areas. And one of the issues there will be whether that will be with co-location with primary health networks, that isn't yet clear. In mental health, there's significant expansion in response to the Productivity Commission report on mental health, funding for prevention and early intervention and suicide prevention, including an innovative new approach to post-initial attempt for suicide, which is a program which is being explored. There's a whole set of new treatment services, particularly targeted at the so-called missing middle in mental health, which will be services which look more like community mental health services. There's an expansion of the Head to Health program and an expansion of the Headspace program for young people. In terms of other areas for primary care, there's a 1-year extension on the after hours funding for general practice. There's an extension of the respiratory clinics funding for COVID. There's an extension of adult and child dental funding, a 1-year extension. And then there are some increases in bits and pieces. So there's an extension, there's an increase in funding for GPs to participate in, to provide services in aged care, residential aged care. So the incentive funding for doing that has been significantly increased, and there's an increase in GP funding for bulk billing in rural areas. And then there's a series of bits and pieces in women's health and a toe in the water for voluntary registration for people in general practice, mainly setting up the IT system for doing that. There are some gaps in the budget, which really have to do with the fact that there are no significant structural reforms and no significant changes in arrangements for payment and coordination. Now, this is particularly, and the other area which is at the moment still a problem will be the prevention and management of chronic disease. So there was no real increase in funding for prevention and management of chronic disease. And although the dental scheme has been extended, that hasn't been addressed in any major way, and there'll still be major gaps. And one of the most significant areas of need in Australia is still dental health. Those structural issues will be important in terms of the mental health reforms, because the state provides many of the mental health services, the majority of mental health services, and the Commonwealth is progressively moving into that space. So there's a question about how the joint commissioning arrangements for mental health will work when the new centres are set up. That isn't entirely clear yet. I expect there'll be a move towards increased coordination between the state and the PHNs in order to deal with those mental health commissioning issues. That will be important, otherwise it will lead to fragmentation and duplication. So it will be important that there is a focus on joint commissioning. The other area that will be important there will be how primary care intersects with the aged care reforms and how they're coordinated at the local level. The move towards increased home and community care means that more and more services will be provided at home. The way that will be brought together with primary care is still an open question. One thing that's been proposed and is being supported in this budget, but not really, the detail hasn't been clarified, is the idea of aged care general practices emerging and accrediting aged care general practices. Commonwealth's left that open a bit and really left that more with the RACGP to sort that one out. But that was a recommendation of the Commission. There will also be a question about how general practice integrates with home and community care program into the future, so that more services provided at home. And the other part of that will be the telehealth expansion, which obviously, I should have mentioned that earlier. There's been an agreement that the telehealth items will continue, and they will be important for people in rural areas in particular, and in people who have got home and community care needs. So overall, before we go to the question and answer session. I think there are a number of important and significant initiatives here, particularly in the aged care space, but overall it's a fairly modest budget for primary care. There are no major structural changes, and it's probably the case that a number of the initiatives are waiting for an election to occur, and we'll see what happens after the next federal election, whether there are any major reforms in the primary care space. So I'll stop there, Chris, and happy to take questions, and we can see where we go from here.
Thanks very much, Helen. I see people taking notes studiously, so I think that was a terrific overview. Thank you. All right, and there are questions coming through on Slido, so I'll go through these. But the first question that's been asked is, what will be the biggest impact on the primary care sector as a result of the budget? And Hal, it'd be really interesting to get your perspective on that, just in relation to probably a focus on the PHN commissioning pillars and some of those things that you've spoken about: voluntary patient enrolment, telehealth, MBS items, aged care reform.
Thanks, Chris. Look, I think that probably in just straight up and down terms, the mental health commissioning will be a very significant change. I think it's around about 1.4 billion, thereabouts anyway. It's in the billion. It's a little over $1 billion of additional Commonwealth funding for treatment services, and that sets up, I think it's in the order of 55 new head to health centres and an expansion of the headspace arrangement. So obviously that's going to require a whole lot of planning as to where those goes, how they integrate with state-based services, and that will be different in different states. So Western Australia will do it differently than Victoria, but basically that will be a significant impact for those people who have, ongoing needs in the community, ongoing mental health needs in the community. The telehealth and the digital space is, I'm not telling this audience anything new to say that that's a huge change which we are only just dipping our toe in the water of. Today, the fact that I'm doing this presentation this way, setting aside any technical issues which are there, just highlights how the world is changing so dramatically in this space, and that's just going to keep going. So what that will mean for primary care is just enormously increased capacity boost that will need to occur to get on top of how to do all this. It has enormous advantages for patients, for clinicians, so that's important. The telehealth item changes that have been announced are important. It's interesting actually that most of that is probably in phone consultations at the moment. Video consultations are yet to really become a major way forward, but I expect that there'll be practice changes over time as it becomes much more possible to bring clinicians together through video conferencing. So you can bring a specialist into a consult with a GP, you can bring them in, you can bring psychologists and so on into consults. You can do short secondary consultations with patients in the room. So a whole range of possibilities start to emerge which aren't which have yet to be explored in detail. I think the aged care changes will be significant as we see more and more frail older people being supported at home. There'll be new models emerging for sorting that out. And that will have an impact on how you bring primary care services into those models and how you integrate them. And that'll mean probably thinking about funding systems into the future. And this budget sets up that platform, but there's a fair bit of work to do into the future, Chris.
Thanks, Hal. And that response goes to a couple of the other questions that have come through on Slido. One being, how will digital health increase access to health, and what role do PHNs have with this opportunity to upskill consumers, carers and support workers? And I think that's a really important question around the dual roles in terms of telehealth uptake. So there's the clinician, but then there's also the user of the telehealth, digital solutions, which I think is a really important component to highlight.
Yeah, I think that's right. So the trend, as people in the audience will know, is to move towards greater consumer or patient-centred approaches. And when you unpack that, what that really means is people having greater say in how they want healthcare to be delivered, what their needs are, how that's going to be dealt with, and so on. And that trend is across the board, and the telehealth makes more of that possible. The other part of that, to give you the example, is the creation of the care navigators in the aged care system. And what that role is going to be about is supporting consumers to get the services that they want and need, and to be on the consumer side. And we'll see that emerging increasingly in the healthcare space for people who've got long-term needs, so that we start to see a focus on integrated care being coordinated with consumers having support to achieve that. So all of this trend, the digital trend, the move towards patient-centred healthcare, the idea of bringing video conferencing together is all about bringing things together more in a more seamless and a more integrated way for consumers. And so that's on the one side, and the other side of it is for people like me who are interested in, the overall spending in health and the policy issues and how you put that together to make sure that that's done efficiently. So all of that digital space is also about making sure that you eliminate unnecessary services, that you don't waste money in terms of how services put together, that the quality of those services is well monitored, and that you don't get excessive variations in the way services are delivered. And so that digital space it will be increasingly around both the outcomes for consumers and the way that the funding is used to ensure that we get an efficient and effective healthcare service. So this is a set of reforms which we're about. I guess that we're a third of the way into that, and over the next 10 years, that the pace of that sort of approach will continue to increase.
Thanks, Hal. And then going to that part of the question about PHN role, I'll just call out that WAFA did, during the COVID response, WAFA did a really good piece of work with Connect Groups, and I know Antonella's in the room, around the consumer sentiment and consumer uptake of telehealth, which was a really good foundation for understanding some of that consumer perspective. So that was a great initiative, I think. So Hal, the next question that has come through, and this is an interesting one. Someone says, am I right in that there is limited primary care reform embedded in the budget? And you and I have spoken about that. I think it'd be good for the audience to hear your perspective on that.
Yes, I think so what's happened is we've seen in the primary care space a set of incremental changes on items, particular items, incentives here and there, the extension of the after-hours funding and so on. As I said, the major reforms are in aged care and mental health, so they intersect with primary care, but they're not principally focused on primary care reform. So it's a holding budget in that space. I think the COVID, so if I look back for a minute, Chris, I think the COVID experience has demonstrated to the Commonwealth that coordination through primary health networks has been very important to be able to deliver on a range of just challenging issues which have been experienced, setting up respiratory clinics, getting testing going, getting PPE out, sorting out a whole range of issues in relation to COVID, dealing with, the aged care, the residential aged care issues, et cetera, et cetera. So primary health networks have demonstrated that to the Commonwealth that you have to have regional and local capacity to deal with those issues. Now, where the Commonwealth goes into the future, trying to sort that out and trying to coordinate with the state is yet to be determined. But it's pretty clear that some of those issues have been highlighted. The Commonwealth looks like it's continuing to go in the direction of commissioning, and it needs a commissioning agent at the local level or at the regional level to do that. So PHNs look like they are part of the furniture, the architecture which will be needed for the future to do that. And then the question is, how do you bring that together with the state-based services so that it that it's properly coordinated and integrated in a sensible way. And as you say, there's been a fair bit of work on that already, but this budget hasn't fundamentally addressed those structural issues.
Thanks, Hal. And that goes to answering one of the other questions that's come through in terms of what would the governance of joint commissioning look like. And I think we can say that there's a lot of signals in the budget, but also in other policy reform frameworks and strategies that really talk to joint regional commissioning. I think the governance structures are less clear, but certainly there would be some indicators around that governance.
In a more sensible world, you would set up regionally based planning, funding and commissioning arrangements with evaluation of performance and so on, and an integrated governance arrangement so that you solve some of those issues. Both the Commonwealth and the states tend to be cautious about letting go of control of their own funding streams and their own initiatives. They like to have those areas protected within their budgets and so on. So it'll take a little bit of work to get that to go forward. The elements of it, though, are really thinking about, in Australian terms, catchment populations, planning for those catchment populations, then determining the budget and the funding streams for those populations, and then jointly bringing the state and Commonwealth funding together in a way which achieves a common set of outcomes, and having a performance framework to make sure that that's actually happening. So the more you fragment all of those elements, the more it's a challenge for providers on the ground to bring that together. Because in the end, what providers have to do is cobble together the money, which is coming from the Commonwealth and the state, to deliver services. And that's the challenge which is there at the moment. So I think everybody recognises that, and there've been some, as you say, there've been some steps to move in that direction, but we haven't yet got an overarching agreement about that.
Thanks, Hal. And just as I'm seeing the questions coming through, one of the things that I would say is that there are some specific questions regarding contracted services funding for contracted services. And just to note that these will be addressed by WAFA as we get more detail through on the budget from the Commonwealth PHN branch, and correspondence regarding specific commission services will be coming through to current providers within the next week. So I won't deal with those specifically because we do need more detail and we do need to have those discussions with providers. Hal, another question that's come through is what are the current issues and concerns for frail older people in the primary and community care system, and will the increase in home care packages and the GP Access Initiative address these?
Okay. There are the biggest issue that people frail older people have faced, and those of you who are either responsible for providing services or who've had personal experience of this know that has been the waiting times for getting access to home and community care services. So the waiting times for home and community care packages at the moment are around about a year. And there are a whole lot of cobbled together arrangements to try and provide those services for people. The issues then become that we have a fragmented assessment system where you have regional assessments for the home support program. Then you end up with the ACAS. I'm not sure if they're called ACASs in WA or ACATs, but the ACAS assessment then for home care packages and for residential care. And you get delays in that, and then you have there are just access pathway issues from GPs through to ACASs and sorting out exactly what you can get when. And it is a real challenge for frail older people and their families to sort out how you get through that set of access issues. And so we get a whole lot of gaming going on, a whole lot of fragmentation in how that works. You also get a whole series of issues in relation to means testing and the co-payments in those packages. So those issues are the reforms are meant to address those issues by setting up a single assessment pathway, bringing those issues into clearer focus, providing care navigators to help people to support, help older people to find their way through these assessment pathways and then to services. And part of that will be, I think, for PHNs, will be setting up programs to inform the primary care system about how that's all going to work, so that people get clear information about that. It kind of a health pathways kind of approach to sorting that out, because otherwise the primary care system will struggle to figure out how it intersects with that new aged care system. So that will be important. The access payments for residential care will be important, but there's still a fair bit of work to do on sorting that out. Using item-based payments is not the only way you could sort that out, or using incentive payments is not the only way of sorting that out. New payment models could be constructed. That hasn't yet been thought through, and there's a bit of work to do. So we're at the early stages of that as to where that will land. So they're the sorts of issues that consumers are facing at the moment, and I think consumers will want some much more streamlined, clearer, supported pathways to get access to aged care services.
Thanks, Hal. A question here that goes to economics and the dollars for mental health. So the question is, mental health funding is $11 billion. Given the high prevalence of mental health issues, how significant can these changes be? And I guess that question goes to what's the direction for change for mental health into the future?
Yeah, that's a good question. Look, the way I think about this, and the way the Productivity Commission thought about it, was that there's a very interesting graph in the Productivity Commission report, which sort of highlights that there is probably overspending on people with relatively straightforward, if you like, problems of living, and they are in some distress, but they're not significantly in distress, and there's probably overspending in that area. So the solution to that is to provide people with more self-help and online support and let them through. And there's probably significant underspending on people who have a significant set of distressing conditions occurring either on a short-term basis or on a long-term basis. And the group that misses out is the group that's the so-called missing middle. The people who've got significant issues, they're distressed, they're struggling with work, family, there are a whole series of issues that they have to address, that they need help with, but they're not going to end up in hospital. And so there's a missing set of services in the community for that. So the trick with all of this is identifying the pathways for those people so that you don't lose them, and setting up a set of services which are well positioned to help them through to dealing with the psychological and the medication management issues, and then helping them to sort out their issues with their families and with work, and reintegrating into the community and so on, and providing them with a relatively more intensive longer term episode of support, and at the same time having clear pathways to that. So referral pathways, making sure that those services are provided in a timely manner, particularly when you've got suicide risks and so on. So that's the real challenge with that. And at the same time, not seeing an endless expansion of mental health out into minor areas. So that's the challenge. It's actually about spending the money more wisely and getting a coherent system together to make that work. And that is the direction that the Productivity Commission is suggesting we go in. And so setting up those centres, those community-based centres, is the direction I think that governments are going in. Certainly the Royal Commission reforms in Victoria have essentially recommended the same sort of direction as the Productivity Commission, and this spending which is being proposed by the Commonwealth. That is to set up competent community-based mental health services, and then to provide a pathway to those for people with those more significant difficulties who are otherwise ending up in emergency departments. And so being able to support them while at the same time not having this opened up to too great a set of conditions which can be managed reasonably straightforwardly in other ways. So that's the challenge, Chris, is seeing that set of reforms coming through. The Commonwealth put its toe in the water with 50 centres nationally, and each of the states will be thinking about how are we going to bring those things together. And that's the point you were making earlier about the joint commissioning and planning.
Which again, I think is a really, that's quite a focus area for PHNs, and, and really leveraging some of the work that we have been doing in building those relationships with the state and the Mental Health Commission in our experience. And I think, Hal, too, in some conversations that you and I have had, you actually see this as being quite an opportunity for WA in terms of WAFA, the WAFA model, and the potential for innovation in Western Australia.
Yeah, well, as a former Western Australian and one who still has family in Western Australia and who comes over every now and then, I know that there's this sense of Western Australia being a bit isolated from the East Coast, the so-called over East people, and in a sense, that isolation and that distance is also a great plus for WA because it gives WA an opportunity to do innovative things that are self-contained. And I think the good thing that's happened, a really significant opportunity in Western Australia is that that WAFA, West Australian Primary Health Alliances, is an integrated model. In many of the other states, each of the PHNs are still relatively separate from one another. Whereas in WA, you do have the capacity for the primary health, the Commonwealth-funded primary health component to talk directly to the state as one voice. And that means that you can set up innovative ideas. So whenever I look at policy initiatives, when we do that at Grattan and when I've done this in other jobs that I've had, you tend to think about, well, where can you trial things? Where can you look for innovation? And you inevitably end up with either Tasmania or the Northern Territory because they're small and contained. But I think WA has real opportunities for coming up with some innovative ways of commissioning, sorting out issues, trialling things. It will depend on goodwill between the Commonwealth and the state and between the PHN and the state to make that happen. And I think there's real opportunities to do that, Chris.
Yep, and I think we'd agree, Leanne, would we not? There's a question here, Hal, that goes to prevention. And the question is there any evidence in the budget of a stronger focus on preventative care? And I think, the budget certainly, put a signal towards the 10-year national preventive health strategy. And there was a little bit in there on cancer screening and, particularly breast cancer and cervical tied in with the women's budget.
Yeah.
But what's your thoughts on prevention in the budget?
Okay, that's a good question. Look, you're right. There are some signals. The cervical cancer screening, the breast cancer screening in the women's health budget. I think the Commonwealth has identified that it may have a problem with women, and so it's putting a bit of effort in to create a few signals. I'm not sure how significant these ones are, but overall, I think there are some early indications, but prevention has not yet made it back onto the agenda in the same way as, say, aged care or mental health has. And so there's a lot of work to be done. I think we've seen prevention have a somewhat different focus over the last year than we previously had thought of because of the infectious disease issue suddenly coming back. And so, when I spent a long time in the past when I was the Dean of Health Sciences thinking about epidemiology and prevention and diseases. And for many years, people didn't take it very seriously. And now, of course, we've suddenly seen what happens when you don't take infectious disease prevention seriously. And so we're seeing a big effort on that front, and we will continue to see a big effort on that front in vaccinations and so on. The area which is probably missing at the moment, Chris, is chronic disease. So we've got cancer screening and so on. You could call that a chronic disease, but I think, it's still the case that we're heading towards 60% of the population being overweight or obese. We've got still got a major set of issues in terms of alcohol, drugs and tobacco, et cetera. We've got a set of gambling issues that have emerged. So there isn't yet a coherent approach which has been localised through PHNs or the states and the Commonwealth for a major prevention initiative. So there are bits and pieces here and there, but we don't have a major national agency for prevention, and we don't have a full-scale chronic disease prevention program. We'll have to see if that emerges.
Yeah, and going to the point about chronic disease, I think there was some quite good case studies that were pointed out in the recent Productivity Commission report into chronic disease programs. So, given the attention that some of the Productivity Commission topics do receive, I think scaling out some of those best practice example of chronic disease early intervention and management could be a useful way forward.
I think that's right, Chris. And what we've had is many trials and case studies, and what they've all demonstrated is that on a small scale you can get significant improvement. The question is, how do you scale it up? And that's what the debates about integration and commissioning are about, really, is can you scale those things up to address those issues into the future? We haven't yet done it, but there are, and that's the issue of then changing some of the structural elements. The toe in the water in the Medicare review last year, which landed just before Christmas, was, of course, the idea of enrolling patients and registering them. So we're not using the word enrolling at the moment, we're using the word registering. And that's a sort of a step in that direction to try and start to address those issues. But at the moment, we've got lots and lots of individual initiatives to try and address those issues. There are many of them in WA, as you know. You and I have had those discussions. So it's not that there isn't anything happening, it's that we just haven't pulled it together into a coherent framework yet.
Yep, good points. Thanks, Hal. And I'm conscious that we're going to be beaming out to colleagues in rural and regional areas once we've got the video and everything sorted. Hal, would you be able to comment on what you see could be the efficacy of the increases in the MBS items for rural, regional and remote GPs in the budget? Now, there has been some talk that those items so this is an increase in MBS items that GPs can apply in country areas. And I think there's some sentiment that it's a bit of a drop in the ocean from peak organisations, but it'd be really interesting to get your perspective on whether the increase in those items are likely to have an impact on retention and attraction of GPs in rural, regional and remote Australia.
Look, I think they're welcome in the sense that they'll make a little bit of difference here and there. I think the reality is that this approach of individual item-based funding will continue to be marginal for rural general practice and other forms of practice in rural areas. I'm sure your audience knows that the issues really are about sustainability in small communities. They're about people making the major step of relocating the entrance and then having some confidence in being able to exit if they find that their circumstances change and they want to practice somewhere else. And the other part of it is that they feel isolated. You become a sole practitioner in rural communities, and so bringing that all together means you have to have an integrated approach to this. The payment really matters in terms of taking risk out for people so that they feel that they are going to get a reasonable income, that they're not going to take a risk in terms of establishing themselves, and that they can exit when they're in those environments. And the issues really need to be addressed in a more integrated way, really. Some of the things that have been done in WA have been pretty good in terms of supporting all of those issues through setting up essentially a support agency that provides support to rural practice. But probably we're not going to solve it through changing item level incentives alone for rural general practice. It's going to require a more integrated funding model to achieve that. Today is not the place probably to try and address all of that, but in response to the budget, I think it's a useful measure, but it's not going to solve the problem.
Yep. Thanks, Hal. Now, there's a question here that I hope you can answer because it's got a lot of thumbs up on the Slido. Can you comment on NDIS, both funding and in brackets governance, and care integration, especially the role, including the expected role of GPs?
Yeah, it's tricky, isn't it? The NDIS, it's controversial at the moment. It's good that the funding has been extended and that there's a commitment to fully funding the NDIS and to sorting out the issues that are there. I'm notwithstanding all the thumbs up. It's a challenging area to sort out. Most of the NDIS issues are implementation issues. The model itself is a great model. I certainly think it's a good model overall. In terms of the integration of general practice with NDIS, the issues are probably ones which are going to have to be sorted out over the next 3 or 4 years as some of the final rollout phases of the NDIS occur. I guess my sense of the NDIS is that it's like the aged care reforms. It's still settling down, Chris, and there's still a bit of work to do to make that, to deliver that. So I'm sorry I can't give your audience a definitive answer on that. I'm still in the camp that says we need to wait and see a bit where that lands over the next 2 or 3 years. I think the government's still finding its way on that too.
Thanks, Hal, and I'm sure I can see that very interested people from the disability sector who would like to have some lengthier conversations on that topic.
Yeah, I'd like to do that, but I don't think it would get into too much detail today, I think.
Yep, agree. Another one that's interesting is how will Aboriginal health be enhanced by the government's commitments in the budget? That's a really interesting one, I think. I think there was an overall commitment to, to the increased participation of the ACHO sector, for example, that we saw. The specifics and the detail were a little bit harder to find, but you may have looked in much more detail on that one.
No, I probably haven't looked as much. I know that there was a $0.6 billion increase in the budget for the Indigenous sector and obviously funding for ACHOs. And there are also there's a major initiative in the aged care space to have an Indigenous funding stream for in the aged care reform. So the Indigenous sector is still one which government continues to take seriously. So there are a number of initiatives in the Indigenous space for in the budget, and there is a significant increase in spending for Indigenous health. So it hasn't been ignored. To be fair to the government, I think that's it's in there.
Great, thanks, Hal. And Jane, I'm relying on you to give me signals when we're needing to wrap up. But we've still got questions coming through, so I'm just going to keep going, and we'll
Not a problem.
Keep making the use of your time. Now, this one is another one that I think is very relevant, and would be great to get your take on this one, Hal. Will the data of patient-reported outcomes be captured to ensure the outcomes consumers are seeking is achieved in both aged care and healthcare?
Good question. So one of the things that's happened is the My Health Record is now being seen as the platform to use in residential aged care. So the budget provides some funding for that and moving in that direction. Now, that's going to be a challenge because many of you know that the My Health Record system is still working its way through. I think we still have over 40% of the My Health Records don't have anything in them at the moment. So that's a significant issue. In terms of the outcome measures, there's been a significant focus in the reform strategy to improve the quality of data in residential aged care. So better reporting, more closer monitoring, more on the ground quality checking as to what's going on. So there's been a recognition that does need to be addressed. As I said earlier, the digital space makes a whole lot of that possible, which previously would have been more challenging. And so people are working. I think the reforms in aged care will see greater level of reporting in that space. I think residential care will be the focus because of the experiences that were reported at the Royal Commission. The area where we'll need to see how we go in the next 3 years as the reforms roll out is home and community care. There is a recognition, and for those people in the audience who are involved in the aged care sector, that won't come as a surprise, that there is now a considerable concern about the value for money which is being delivered through the home care packages, and there will be an increased emphasis on demonstrating value for money in those packages through reporting and some of the initiatives which have been proposed in the budget to put pressure on to make sure that that money is well spent. There's too much is being spent on administration at the moment and not enough on service delivery. And so there's going to be much more pressure to see that happen. In terms of the outcome, patient-reported outcome measures, there's a good deal of interest in that, but that's still an area which has got to be fully developed. There's no fully developed system for doing that at the moment.
Great, thanks, Hal. There's another one here that goes specifically to MBS items and probably, the recommendations from the MBS task force. And I think, in the context of the budget, this question's being asked, was there any recognition of the need for more item numbers for allied health and nurse practitioners?
I'm just thinking about that. I haven't looked at the detail, but there's certainly some extension of funding for allied health. Can't remember whether it was nurse practitioners as well. There's certainly extension of funding for allied health in aged care. Allied health being provided in residential aged care. And there is obviously the continuation in the mental health space for the COVID items and the way that works. So there, I'm just sort of rolling through in my mind when I read the budget papers what I saw there. And I'm just doing this impressionistically, so don't hold me to this. But my sense was that there was a recognition that we had to see some extension of the allied health services through the Medicare system. I can't recall anything on the nurse practitioner items.
I didn't see anything specific on nurse practitioner items coming through in the budget. So I know that will disappoint, many. That role of the nurse practitioner, I think has certainly been advocated for, but I didn't see evidence of it in the budget. Okay, we've got time for one more question. So I will go to. Oh, that one might be a bit technical. There's a technical one here about QR code apps. So I'm going to ask Giles this after the session, and we'll get back on that one. I'm not sure. How do you think you and I are well placed to answer that one? I don't think so.
No.
So Giles, our esteemed digital health colleague, I'll take that one up with Giles after the session, or in the networking afterwards. The person who asked that question, Giles is just there, and so I think he'd be more than happy to answer questions about apps and QR codes. And this question, Hal, if you can't answer this one, I'm sure my colleagues in the room, Danny, I'm looking at you, may be able to answer this one. But the question is, do we yet know how many of the adult and children's mental health centres will be located in WA? And we're getting lots of
good question. So I'm going to let your colleagues answer the detail, but I think from memory that the rollout is 8 initially and 20-something satellite centres will occur. And I am assuming that there will be at least 1 or 2 of those in WA, but I'll leave that detail to your colleagues. I haven't looked in specifically where they're going to land.
Thanks, Hal. Yeah, and that wasn't clear. And Leanne and Danny are both nodding their heads. So no is the answer to that question. So that was my last question. And Hal, I'd just like to say on behalf of everyone here, thank you very much for your wisdom and your, the benefit of your vast knowledge and experience in answering these questions. I know your time is valuable, and you've very generously given your time to us today, and your willingness to discuss these policy conundrums with us at WAFA on a regular and ongoing basis is really is really well received by us, and so I'm sure everyone would want to join me in thanking you so much for your time and your energy in answering the questions.
Thank you very much, Chris.
Thanks, Hal, and take care, and we'll talk to you again soon.
Thanks very much, Chris.
Okay, so I'll hand over to Leanne for wrapping up.
Thank you all very much. I imagine you've all got your own takeaway messages, but I thought it was quite important when Hal said this is a holding pattern budget. And I think, on one hand, we're hearing it's a big spend budget and so forth, are we not? And I thought, yes, he's right when you look at it as a whole. And we do know that there will be an election in the next 12 months or so, so it will be an interesting thing to watch. I wrote down just a few notes, and I think largely what Hal reinforced for me is to really achieve the outcomes we would all want in the health sector, for want of a better term. It needs to happen, things need to happen both locally, regionally, and then, statewide and nationally. And that, in a sense, there are systemic impediments that aren't necessarily addressed in this budget, but maybe some signals about some things that might enable better joining up of care, so to speak. So anyway, there was some good, I must admit, it was quite helpful for me just to think through that. We look at the budget because we want to understand what is the government's policy agenda and where are they going and how do we fit with that. And so it's, thinking through how do we make sense of this busy environment. I must admit, as I might have said to myself or some of you. I've probably had 4 or 5 budget briefings this week, and I'm still getting clear on what does that actually mean on the ground and how will we progress that. But anyway, all good. We've all learnt to live with a little bit of ambiguity and uncertain over quite a bit of time. However, he said some really interesting things, so I think it was a very helpful discussion. And thank you very much for being tolerant around the IT. My colleague Hamish and I think that on windy days it's actually much harder than on non-windy days, and we're going to test that with you, Giles, because yesterday it was blowing the clappers and we both had really poor Wi-Fi. So I'm not sure if that was happening in Dalesford. It could have been. Giles looks at me like I'm a nut, see? Don't you love that? Anyhow, so thank you all for bearing with us and with us having a little bit of courage for not only coming together, which we think has been a fabulous thing, but also bearing with us through some of the IT challenges. Great job, Chris. Thank you very much. Great job to the team too for best endeavours making the IT work, but also organising us. Please stay, have some morning tea, spend some time with your mates, given you were going to originally give up many more hours than the 2 that we've spent. So you've got a little bit of free time, I hope, to spend some time together and just talk through how you understood that conversation and for you, you know, just network a bit. So I think that's all I've got to do, isn't it, Jane? Thank you all for coming. Thanks for making the time, and it's lovely to see you all. Morning tea is over there. Coffee is over here.